Hello students, I am Gandharva Hemant Pednekar, Research Associate, School of Development Studies, Tata Institute of Social Sciences, Mumbai. I will be discussing about the module on National Health Programs and Schemes in India, Part B. Mission Indradhanush. The Government of India is committed to reducing child mortality and morbidity in the country by improving full immunization coverage through Universal Immunization Program and introducing new and efficacious vaccines for vaccine preventable diseases or VPDs. India's immunization program, launched in 1985, is one of the largest health program of its kind in the world, catering to a birth cohort of 2.7 crore children annually. The program provides vaccination against 7 life-threatening diseases, namely diphtheria, whooping cough, tetanus, polio, tuberculosis, measles and hepatitis B in the entire country. In addition, vaccination against Haemophilus influenzae type B, that is HIB, and Japanese encephalitis JE is provided in selected districts or states of the country. Despite being operational for the past more than 30 years, only 65% children in India receive all vaccination during their first year of life. It is estimated that annually more than 89 lakh children in the country do not receive all vaccines that are available under the UIP, the highest number compared with any other country in the world. As a strategic endeavor, the Ministry of Health and Family Welfare, Government of India, launched Mission Indradhanush in December 2014 to achieve more than 90% full immunization coverage in the country. This initiative will eventually close immunity gaps and strengthen immunization coverage. Rationale for Mission Indradhanush evidence shows that unimmunized and partially immunized children are most susceptible to childhood diseases and disability and run a 3 to 6 times higher risk of death as compared with fully immunized children. There are wide variations in the proportion of partially immunized and immunized children within states and districts. Recent evaluations have indicated that the major reasons for inability to reach with all vaccines to children in the country are lack of awareness among parents about the benefits of vaccination, fear of adverse events following immunization, and operational reasons such as non-availability of vaccines or vaccinators during vaccination sessions. It is critical to identify the unvaccinated or partially vaccinated children and address these issues with focused microplanning, provision of additional financial resources, and systematic immunization drives to reach these children with all available life-saving vaccinations. Objectives and strategy. The objective of Mission Indradhanush is to ensure high coverage of children and pregnant women with all available vaccines throughout the country, with emphasis on the identified 201 high focus districts. Specific objectives are: with the launch of Mission Indradhanush, the government aims at generating high demand for immunization services by addressing communication challenges, enhancing political, administrative and financial commitment through advocacy with key stakeholders, and ensuring that the partial immunized and unimmunized children are fully immunized as per National Immunization Schedule. Areas under focus Mission Indradhanush will be a nationwide drive with focus on 201 identified high focus districts. Key areas reached through Mission Indradhanush will be areas with vacant sub-centers, no auxiliary nurse midwife posted for more than 3 months, villages, areas with 3 or more consecutive missed routine immunization sessions, that is ANMs on long leave or other similar reasons, high risk areas HRAs identified by the polio eradication program. These include populations living in areas such as urban slums with migration, nomadic sites, brick kilns, construction sites, other migrant settlements like fishermen villages, riverine areas and shifting populations. underserved and hard to reach populations, that is forested and tribal populations, hilly areas, etc. Areas with low RI coverage identified through measles outbreaks, cases of diphtheria and neonatal tetanus in last 2 years, small villages, hamlets, danis, purbas, basas, that is field huts, etc., clubbed with another village for RI sessions and not having independent RI sessions. The program focus is as follows. Hepatitis. Hepatitis is inflammation of the liver. The most common cause of infection is one of the 5 viruses called hepatitis A, B, C and D. All of these viruses can cause an acute disease with symptoms lasting several weeks, including yellowing of the skin and eyes, that is jaundice, dark urine, extreme fatigue, nausea, vomiting and abdominal pain. Among all the forms of hepatitis, hepatitis B virus HBV is a major cause of concern worldwide. Around the globe, about 2 billion people have serological evidence of current or past HBV infection. In India, it is estimated that at least 1 lakh people die every year due to illness related to HBV infection. Prevention of hepatitis B. Keeping away from contact with the blood and body fluids, including semen and vaginal secretion of infected persons, is the most efficient way of preventing any infection from settling in. Avoid sharing personal items such as razors and toothbrushes with individuals who are infected with the hepatitis B virus. Use latex condoms to prevent getting infected through sexual contact. Vaccine protecting against hepatitis B are available and should be seriously considered by people exposed to a high risk of infection, such as those who receive blood transfusions, share needles for drug use, or have multiple sex partners. Individuals who come into direct contact with the blood or body fluids of a carrier of the hepatitis B virus may receive 1 or more injections of the hepatitis B immune globulin, sometimes together with the hepatitis B vaccine. The immune globulin offers temporary protection while the vaccine provides long-lasting immunity against the disease. Diphtheria. Diphtheria is a serious bacterial infection that affects the mucous membranes of the throat and nose. Although it spreads easily from one person to another, diphtheria can be prevented through the use of vaccines. What causes diphtheria? A type of bacteria called Corynebacterium diphtheriae causes diphtheria. The condition is typically spread through person-to-person contact or through contact with objects that have the bacteria on them, such as a cup or used tissue. You may also get diphtheria if you are around an infected person when they sneeze, cough, or blow their nose. Even if an infected person doesn't show any signs or symptoms of diphtheria, they are still able to transmit the bacterial infection for up to 6 weeks after the initial infection. The bacteria most commonly infect your nose and throat. Once you are infected, the bacteria releases dangerous substances called toxins. The toxins spread through your bloodstream and often cause a thick gray coating to form in the nose, throat, tongue, and airway. In some cases, these toxins can also damage other organs, including the heart, brain, and kidneys. This can lead to potentially life-threatening complications such as myocarditis, paralysis, or kidney failure. Risk factors. When we talk about the risk factors related to diphtheria, we can see that children in the United States and Europe are routinely vaccinated against diphtheria, so the condition is rare in these countries. However, diphtheria is still fairly common in developing countries where immunization rates are low. In these countries, children under age 5 and people over age 60 are particularly at risk of getting diphtheria. People are also at an increased risk of contracting diphtheria if they aren't up to date on their vaccinations, visit a country that doesn't provide immunization, have an immune system disorder such as AIDS, or live in unclean or crowded conditions. So what are the symptoms of diphtheria? Signs of diphtheria often appear within 2 to 5 days after the infection occurs. Some people don't experience any symptoms, while others have mild symptoms that are similar to those of the common cold. The most visible and common symptom of diphtheria is a thick grey coating on the throat and tonsils. Other symptoms which are common include a fever, chills, swollen glands in the neck, a loud barking cough, a sore throat, bluish skin, drooling, and a general feeling of uneasiness or discomfort. Additional symptoms may occur as the infection progresses, which include difficulty in breathing or swallowing, changes in vision, slurred speech, signs of shock such as pale and cold skin, sweating, and a rapid heartbeat. You may also develop cutaneous diphtheria or diphtheria of the skin if you have poor hygiene or live in tropical area. Diphtheria of the skin usually causes ulcers and redness in the affected area. How is diphtheria diagnosed? Your doctor will likely perform a physical examination to check for swollen lymph nodes. They'll also ask you about your medical history and the symptoms you have been having. Your doctor may believe that you have diphtheria if they see a grey coating on your throat or tonsils. To confirm the diagnosis, they'll take a sample of the affected tissue and send it to a laboratory for testing. A throat culture may also be taken if your doctor suspects diphtheria of the skin. So how is diphtheria treated? Diphtheria is a serious condition, so your doctor will want to treat you quickly and aggressively. The first step of treatment is an antitoxin injection. This is used to counteract the toxin produced by the bacteria. Make sure to tell your doctor if you are allergic to the antitoxin. They may be able to give you small doses of the antitoxin and gradually build up to higher amounts. The doctor will also prescribe antibiotics such as erythromycin and penicillin to help clear up the infection. During treatment, doctor may have you stay in the hospital so you can avoid passing your infection on to others. Preventing diphtheria. Diphtheria is preventable with the use of antibiotics and vaccines. The vaccine for diphtheria is called DTaP. It's usually given in a single shot along with vaccines for pertussis and tetanus. The DTaP vaccine is administered in a series of 5 shots. It is given to children at the following ages: 2 months, 4 months, 6 months, 15 to 18 months, and 4 to 6 years of age. In rare cases, a child might have an allergic reaction to the vaccine. This can result in seizures or hives, which will later go away. Vaccines only last for 10 years, so your child will need to be vaccinated again around age 12. For adults, it's recommended that you get a combined diphtheria and tetanus booster shot. This is known as the tetanus diphtheria or TD vaccine. Taking these steps can help prevent you and your child from getting diphtheria in the future. Now we'll discuss about the Janani Suraksha Yojana. Janani Suraksha Yojana or JSY, under the overall umbrella of National Rural Health Mission NRHM, is being proposed by way of modifying the existing National Maternity Benefit Schemes, that is NMBS. While NMBS is linked to provision of better diet for pregnant women for BPL families, JSY integrates the cash assistance with antenatal care during the pregnancy period, institutional care during delivery, and immediate postpartum period in a health center by establishing a system of coordinated care by field level health worker. The JSY would be a 100% centrally sponsored scheme. Vision of scheme is to reduce overall maternal mortality ratio and infant mortality rate, and to increase institutional deliveries in BPL families. The target group are all pregnant women belonging to the below poverty line households and of the age of 19 years or above up to 2 live births. The benefits would be extended to all women from BPL families of 10 low performing states, namely 8 EAG states, that is Uttar Pradesh, Uttaranchal, Madhya Pradesh, Chhattisgarh, Rajasthan, Bihar, Jharkhand and Orissa, and the states of Assam and Jammu and Kashmir. Even after the 3rd live birth, if the mother of her own accord chooses to undergo sterilization in the health facility where she delivered, immediately after the delivery. Satisfaction of the medical officer through a process about the number of living children of the expectant mother would be a precondition to availing the benefits of this scheme. The benefits would also be available to such pregnant women falling in the above category, even though not registered under JSY previously during pregnancy period, but needing institutional care for delivery, including management of complications like obstructed labor, PPH, eclampsia, PP sepsis, etc. State will devise necessary mechanisms for adequate certification from the medical officer of the health institution from where women has taken treatment. This would be essential for disbursement of benefit. The main strategy will carrying out following: early registration of the beneficiaries with the help of the village level health workers like ASHA or an equivalent worker, early identification of complicated cases, providing at least 3 antenatal care and post-delivery visits, organizing appropriate referral and provide referral transport to the pregnant mother, conversion with integrated child development services, that is ICDS worker by way of involving Anganwadi worker AWW intensively, devising as well as ensuring transparent and timely disbursement of the cash assistance to the mother and the incentive to the accredited social health activist, that is ASHA, or an equivalent worker with fund available with ANM. Operationalization of 24/7 delivery services at PHC level to provide basic obstetric care. Operationalization of first referral units or FRUs to provide the emergency obstetric care. Building partnerships through a process of recognition, accreditation with doctors, hospitals, nursing homes, clinics from the private sector, especially in the rural areas, to provide obstetric services to the JSY beneficiaries. Decentralization of the implementation mechanism is the key to making available the benefits to the poor expectant mothers. To achieve this, wherever possible, the Gram Panchayat or local elected bodies should be appropriately involved. National Filaria Control Program. The program launched in 1955 has operational, training and research components. The strategies include A. Vector control, B. Detection and treatment of filarial cases, and C. Delimitation of endemic areas. This is being carried out through control units, night clinics and survey teams. This program continues to be in place in addition to the program to eliminate LF in India. Lymphatic filariasis is the world's second leading cause of long-term disability. Although filariasis does not kill, it causes debility and imposes severe social and economic burden to the affected individuals, their families, and the endemic communities. The current estimate reveals that 120 million people in 83 countries of the world are infected with lymphatic filarial parasites, and is estimated that more than 1.1 billion, that is around 20% of the world's population, are at risk of acquiring infection. Over 40 million people are severely disfigured and disabled by filariasis, and 76 million are apparently normal but have hidden internal damage to lymphatic and renal systems. According to the World Health Organization, India, Indonesia, Nigeria, and Bangladesh alone contribute about 70% of the infections worldwide. It has been estimated that approximately 5 million disability adjusted life years, that is DALYS, lost annually, ranking third among the TDR diseases in terms of DALYs after malaria and TB. In addition, the social and psychological impacts is enormous, often destroying marriages and family. Current status and distribution of LF in India. The disease was recorded in India as early as 6th century BC by Susruta in the book Susrut Samhita, and in 7th century AD, Mahadevakara described signs and symptoms of the disease in his treatise Madhava Nidhana, which hold good even today. In 1709, Clark called elephantoid legs in Cochin as Malabar legs. The discovery of microfilariae, that's MF, in the peripheral blood was made first by Lewis in 1872 in Kolkata city. Indigenous lymphatic filariasis cases are reported from 20 states or union territories, namely Andhra Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Orissa, Tamil Nadu, Uttar Pradesh, West Bengal, Puducherry, Andaman and Nicobar Island, Daman and Diu, Lakshadweep, and Dadra and Nagar Haveli. From these states and union territories, a total of 250 districts have been identified to be endemic for filariasis, with the population of about 600 million at risk. The northwestern states, union territories, namely Jammu and Kashmir, Himachal Pradesh, Punjab, Haryana, Chandigarh, Rajasthan, Delhi, Uttaranchal, and northeastern states, namely Sikkim, Arunachal Pradesh, Nagaland, Meghalaya, Mizoram, Manipur, and Tripura, are known to be free from indigenously acquired filarial infection. Elimination of LF. Elimination of LF is meant that LF ceases to be a public health problem. When the number of microfilaria carriers is less than 1% and the children born after initiation of ELF are free from circulating antigenemia. Absence of antigenemia among children is considered as evidence for absence of transmission and new infection. In 1997, WHO and its member states made a commitment to eliminate lymphatic filariasis as public health problem by 2020 through World Health Assembly resolution. The National Health Policy 2002 has set the goal of elimination of lymphatic filariasis in India by 2015. The Government of India constituted the National Task Force or NTF with Director General of Health Services MOH and FW as chairperson, DG ICMR, Director NCDC, senior officers of health services from states as members, and Director of NVBDCP as member secretary. NTF reviews and recommends the strategy for ELF in India. The twin pillars of LF elimination strategy include 1. Transmission control to prevent the occurrence of new infection and disease by administration of annual single dose of antifilaria drug, that is DAC, and co-administration of DEC plus albendazole. Point 2. Disability prevention and management for those individuals who already have the disease. Home-based management, limb hygiene for lymphedema, hospital-based management, surgical corrections for hydrocele. Major components of functions tasks towards implementation strategy include disease burden estimation, mapping, and stratification. The MDA program will continue with DEC. Albendazole will be added when it is made available from WHO, which has agreed to supply the drug at free of cost for the LF elimination program in India. DEC plus albendazole administration has been included in MDA 2008 onwards in a few endemic states, which will be extended to all 20 states and union territories in the coming years. Advocacy, social mobilization, implementation of MDA, implementation of disability prevention and management, monitoring and evaluation, background surveillance to prevent resurgence, certification of filariasis is a priority. Thank you.